Hello everyone, and welcome to my three-part lecture on EKG and lethal arrhythmias. I first want to give credit where credit's due. Going through the program several years ago, Ms. Inez Kernick previously taught this lecture during a skills course. As an adaptation through the MSN program, we no longer have the skills courses, but I am using some of the bones of her previous lecture and adapting it to this new virtual platform. So over the next few lectures, we'll discuss all sorts of things related to EKG. This first lecture is really focused in on the basics of EKG as far as what the leads are, what we're visualizing with leads, the basics of EKG, evaluating rate, rhythm, all of these basic components. I know some of you may have quite an extensive critical care knowledge and cardiovascular background. I want everyone to try to bear with me and go through these slides as we're talking about the basics. Some of you, this may be pretty new knowledge. You haven't gone through an EKG course in a long time. So this is really an EKG course to accommodate from the ground up and building on this knowledge over the next few presentations. So what are we looking at when we look at an EKG? The electrocardiogram is really a measure of viewing any kind of electrical activity that's going on in the heart. It's by no means a picture of cardiac output. You can see plenty of spikes and other issues in pulseless electrical activity, showing that there's electrical signals that are being picked up by the EKG machine, but that doesn't mean that the patient has cardiac output. We'll talk about cardiac output in later slides, but what you're looking at when you look at the EKG is you're seeing electrical impulses from different parts of the heart. The heart, it's a nice pump, that nice muscular tissue, and it has electrical activity, also known as action potential. When this electrical current is generated, it can actually be measured on the skin surface through the EKG or ECG monitor. Okay. When we're looking at all of these lines that are on the EKG, you'll see kind of more larger defined red lines versus these smaller, minute, faded red lines. The lines up and down represent time and amplitude. When you're looking at one of the little small squares, horizontal, it's 0.04 seconds. That's what it represents. The large square horizontal is 0.20 seconds. So you have 5 little squares for each big square. Conversely or inversely, when you're looking at one small square vertical wise, that's 1 millimeter of amplitude measurement versus on the one large square, that's 5 millimeters. Okay, this comes into more of a play scenario when we are evaluating changes that could be related to ST elevation or deflective waves. So these are important for the basics of understanding EKG. Your normal PRI, which is your PR interval, is anywhere from 0.12 to 0.2 seconds. So any time within that large square is reasonable. Once you start to see that PR interval getting bigger than one big square, that's when we start to see more first degree AV blocks. Normal QRS, that's that big amplitude wave that comes after the P wave. That is a really small time period from 0.04 seconds to 0.1 seconds, less than 3 of those small squares. Okay. And when we start to see that that widens past that 3 small square space, we start to think of bundle branch blocks, and my NP mind starts to think of different meds that cause that issue, whether it be Zofran or fluoroquinolone. Your brain starts to think of different issues when you see different abnormalities. Now, how do we calculate heart rate? Okay, so generally we will count in a 5 large square time period that measures 1 second of time. So if you count the number of QRS complexes, which is pretty much a beat, in a 6-second period, you can multiply that by 10 to get your really good and accurate heart rate. In an ambulatory setting, EKG is generally your best tool for evaluating cardiac arrhythmias other than your physical exam. Unlike an inpatient or an emergency department setting where you can have continuous lead monitoring for an extended period of time, when you do an EKG, it's just a snapshot. And so you are really limited to the findings at that time of evaluation, or the findings that have prolonged effects on that EKG strip. Sometimes you will see some wave abnormalities several hours status post MI, and you can see that on your EKG. So having a basic understanding of reading EKG is important. EKG can help diagnose disorders, and really that's what we're going to be surrounding over the next several lectures. Using a 12-lead EKG as a tool for searching for clues to narrow those differential diagnoses is really what we're aiming to do. So when we are looking at an EKG, this is a somewhat interesting process of evaluating positive and negative electrical fields through the chest wall. Your EKG machine is hooked up with different positive and negative electrodes that are placed systematically on your person. Generally, we see a negative lead on a patient's right arm. They also have a positive lead on their left arm, and we find a positive lead on their left leg. When we are evaluating the patient's EKG rhythm, what we're seeing is the information that's relayed from this negative to positive lead, and it is sent to the EKG machine, and those opposing electrodes, the information that is gathered is interpreted by the EKG machine in the amplitude waves that are displayed on the EKG. The, I think, easiest way to evaluate where the leads are and what they mean as far as where you're visualizing electrical activity in the heart is by this seeing eye picture. So I have 3 eyeballs up here. Lead 1 goes from the patient's right arm to the left arm. That's negative to positive. When you are evaluating where the EKG is visualizing, the best way to think about it is the eyeball is situated on the positive electrode and it's looking towards the negative lead. Now, as this first one goes above the heart, from the right arm to the left arm, thinking systematically it's above the heart, the eye or the picture is looking at the EKG from the top of the heart. Looking at lead 2, which is the one over here on the bottom left, goes from the right arm to the left leg. We're visualizing the heart from that leg up to the arm. So you see that left side of the heart. And when you are visualizing lead 3 is kind of looking from that leg up to the left hand. So you see more of the right side of the heart. And looking at it from these 3 different perspectives can provide you different information as far as, if there's left ventricular strain, or you might have some cardiac ischemia, which shows some different waveforms that we'll cover later on in the lecture. But it's important that you understand that generally when we are looking, we're looking from a positive lead to a negative electrode lead, and that shows us the direction on where we're looking for when we're looking at the 12-lead EKG. This is referred to as Einthoven's triangle. He is the first person to really evaluate heart rhythm through this method of evaluating negative and positive electrodes on the chest wall and hands and feet. In the previous slide, we talked about bipolar leads, which have a positive and a negative electrode, and the information that's gathered from both these electrodes is taken to the EKG machine, and it provides you with these waveforms that shows the electrical activity. On unipolar leads, instead of having a positive and a negative electrode, these leads have the positive electrode with a grounding electrode. Unipolar leads were first found to be helpful in the 1930s. Some medical researchers called the Goldberger brothers really took off with coming up with these following 3 leads that are used in your 12-lead EKG. And instead of using the negative positive lead measure, they were able to create a grounding lead to the patient's right leg that counters the positive lead on the left leg. So this grounding electrode effectively puts a negative aspect on the physiology of measuring the lead conduction, and that's right in the center of the suprapubic area or chest cavity. So this provides a positive versus grounded lead finding where you're able to look directly at the heart from these different perspectives. So these augmented leads are labeled augmented vector right, augmented vector left, and augmented vector foot. So these 3 new EKGs are able to provide a perspective from looking at the bottom of the heart, from diagonally from the left and the right of the heart, which provides 3 more perspectives of evaluating the heart. These leads are automatically augmented by your EKG machine, which is why they're referred to as augmented leads. So this additional perspective can provide a whole lot of information, especially with vector left, looking at that left side of the heart where we might see some significant findings, and the vector right. I don't want y'all to get overwhelmed with this slide. This is mostly just to kind of reiterate what we've talked about in the previous slides. When you combine leads 1, 2, and 3 and the augmented leads, you can see that there is multiple perspectives that you're looking at for the heart electrical activity. Like I said, this is electrical activity, this is not cardiac output. So what we're doing is we're looking at the electrical activity in that heart. You can further break down the leads and how the lead is going from negative to positive, or positive to, or not negative, but grounded to positive. And those are labeled over here, and the kind of directions that they go into. I think that the figure over here on the left is a little easier to kind of understand the perspective on what you're looking at when you look at these vector leads. 10 years later, in the 1940s, the last 6 views of the 12-lead ECG were created. These were more to evaluate the ventricle right there along the chest wall. It was really important as far as evaluating for cardiac function, evaluating for any type of ischemia findings, and it really got a very up-close look at the ventricular function. So the way that you can kind of look as far as these V leads working, I have a picture here of the heart with the chest wall. V1 and V2, you see a good anterior picture of the heart electrical activity. V3 and V4, more so anterior-septal areas of the heart, and then V5 and V6, anterior-lateral visualization of the heart. Now this is kind of a progressive distribution, and so generally what we say is when we're looking at the V leads is we're looking at the progression of the QRS and other waves. As we look through the leads, you can see how the QRS changes from V1 to V6, in that it's really far down and then it slowly goes to an upwards motion. And that has to do with where the heart is in process of creating waveforms and how far away it's being measured. So you start to see some different changes based upon which vector or ventricular lead you're looking at. Okay. Why would we want a better idea of electrical activity of V1 through V6? If we start to see some ventricular ischemia, we can visualize this pretty well with EKG evaluation. So evaluating that left side to see if there's any kind of ischemic damage, we can see by setting up these V1 through V6. Here I have a typical 12-lead EKG. The bottom is your rhythm strip. So this is a good evaluation. You can look at this to generally come up with heart rate. When you're looking at your standard leads, which are leads 1, 2, and 3, those are on the left. Augmented leads are in the middle, and ventricular leads are on the right. When you're looking at these leads, generally leads 1, AVR, AVL are your lateral leads, and then 2, 3, and foot are your inferior leads. So, and then you have your anterior leads, which are your ventricular leads. If you think about it, the ventricular leads make sense to be anterior because it's right on your anterior chest wall. So this is kind of what you're looking at, the anterior, lateral, and inferior when you're looking at your EKG. So having a good idea as far as what part of the heart you're looking at based upon what side of the EKG you're reading is very helpful. Okay, over the next several slides, we're going to talk about some different abnormalities that you'll be routinely looking for in your 12-lead EKGs. It really helps to have a methodology and a systematic approach to reading EKG. So I have listed over here the kind of questions and the method that we'll use when we're evaluating the EKGs. You know, the first section we'll be talking about axis and axis deviation. We'll go into that further in the next slide. But as you're going through and evaluating each EKG, we're going to first talk about what's the heart rate, looking at all of the little red squares and counting that up. What's the rhythm that we're seeing for the patient? The rhythm we'll talk about even more when we're looking at the second presentation, looking at lethal arrhythmias. but we'll talk about that as well. What's the PR interval? Looking from P wave to the R wave, and also looking at the QRS width. All of these help provide us some information as far as what we're looking at the EKG. We're going to look at the axis, which is really where all of the electric potential is flowing through the heart. And we're also going to pay special attention to the lead groups, leads 1, 2, 3, the augmented leads, and the ventricular leads. Looking at these lead groups, we're going to look at any changes that suggest some acute coronary syndrome. Are there T-wave abnormalities, ST segment elevation or depressions, and pathological Q waves? In order for us all to stay on the same page, it's really helpful to have this systematic approach. So as we're going through these processes, first on axis deviation, we will discuss what axis is, and then we'll look at some EKGs that kind of show how to look at that problem. Okay. Before we start breaking off into evaluating rhythms of EKGs, I want to first go into more detail about axis determination. Axis determination really is us looking at the overall electrical activity and flow of the heart electrical motion. So this can be helpful, and it can be can help elucidate any kind of possible problems. I have written down here on the bottom left-hand side some left axis deviation causes versus right axis deviation causes that are more common. So notating whether a left axis or right axis deviation can kind of clue you into some other problems that may be going on. I've included this YouTube video to watch, which I think is very helpful in breaking down axis deviation. So I would recommend, taking a moment to pause and looking at this YouTube, because I think it helps really break it down simple as far as evaluating axis deviation. For the axis of the heart, you have P wave axis, which is actually lead 1, that first lead that goes from the heart directly to the right over here on this picture at 0 degrees. And you have QRS wave axis, which is that plus 60 degrees lead 2 axis. And these can be helpful on evaluating where along the lines of axis determination you're falling. When we're looking at determining axis deviation, it's going to be evaluating if the electrical flow is outside of the normal limit. The normal axis range is anywhere from your AVL axis at -30 all the way to your positive 90 degree AVF axis. So any type of electrical flow between -30 and positive 90 is considered normal. Okay, and we'll talk about more as far as how to evaluate where the axis is in the coming slides. When you have left axis deviation, you're going to have overall electrical flow that is past that -30, and for right axis deviation, you're going to have an overall electrical flow that is outside of that positive 90 degree AVF deviation. Okay, so taking that in consideration, we're going to look at right axis deviation and left axis deviation in the next slide, looking at an EKG. These can really be seen with evaluating lead 1 and lead 2. Lead 1 and lead 2, pictured over here, are within that normal QRS axis area. So evaluating lead 1 and lead 2 can provide us some quick information on if there's a left axis deviation or a right axis deviation. For determining axis determination, we're going to look at mainly leads 1 and 2. Lead 1 and 2 here both have positive inflection on lead 1 and lead 2. We're looking at the isoelectric line and seeing where the QRS and other wave complexes are pointing. Lead 1, the QRS is nice and tall, pointing upward, meaning that it has a good positive finding, and lead 2 is the same way. The QRS complexes are tall and pointy up. So both of these have positive axis determination. So looking at this over here on the right hand side, remember, axis is normal if it's between -30 AVL and +90 AVF. So since we have a positive inflection on lead 1, that gives us good idea that along lead 1, this 0 degrees line, that there is a good positive finding. Same thing with lead 2, that there is a good charge through lead 2. So this tells us that the axis is definitely falling within normal lines of AVL and AVF. Okay, for this EKG, we're going to ignore the fact that there's an ST elevation and probable ischemia going on. What we're looking at is the axis determination on this evaluation. Okay, so to do axis evaluation, we want to look at lead 1 and lead 2. So on this one, we have a mostly positive lead 1 when looking at the isoelectric line and the QRS complexes. When we're looking at lead 2, we see a pretty good negative, almost isoelectric lead 2. So when we have a positive lead 1 and a negative lead 2, we're knowing that we're going to deal with a left axis deviation. Okay. Once we have decided that there is an axis deviation, we want to look at the augmented leads to see which one is the most isoelectric. So looking at AVL, that one's pretty positive. AVF is isoelectric and negative, and then AVR about the same, where it has some negative deflection, but it's also pretty even along the isoelectric line. You want to evaluate the isoelectric line and making sure that you're not just looking at T-wave abnormalities. So I'm going to say that AVR is our isoelectric most lead in the augmented leads. So going to our picture from before, if we say that AVR is our isoelectric lead with this left axis deviation, so we're going to put that as our main isoelectric lead. We're going to go 90 degrees over to the right to determine what degree of left axis deviation we're dealing with. Okay, so if AVR is at a -150, we go 90 degrees to the left, the right, and that tells us that we have a -60 degree left axis deviation. Okay, axis determination for this next 12 lead EKG. When we're looking at axis determination, we're looking at the first and the second lead. So looking at lead 1, we have a negative deflection from the isoelectric line, and lead 2, we have a positive inflection on the isoelectric line. So when we see a negative deflection in lead 1 and a positive or isoelectric lead 2, we want to be thinking that there is a right axis deviation. Okay, so to determine what axis exactly we're looking at, we want to look at which of the augmented leads is mostly isoelectric. So looking at AVL, it's pretty negative. AVF is pretty positive. AVR is, again, more of your isoelectric line as far as looking at the QRS deflections and all that jazz. So if we put in our most isoelectric line on AVR. We're going to go 90 degrees towards the left because this is a right axis deviation, and that puts us at plus 120 degrees. Now, if you notice, look at your lead 3. Lead 3 is really high positive, and that's because there is such a positive charge along that lead 3. So this is also, helping to confirm that you see that right axis deviation, that positive finding in lead 3. So we determine right axis deviation, look for the most isoelectric augmented lead, and that helps us to determine that 90 degrees from that isoelectric lead where approximately we're looking at a right axis deviation. Okay, it would be labeled positive 120 degree right axis deviation. You do have to be careful when you're writing things down and putting out right axis deviation and not RAD. RAD and LAD can be confused with left anterior descending or right anterior descending when you're talking about plaque buildup and ischemia. Here's an example of normal sinus rhythm. So reading through this EKG systematically, first thing we want to determine is the heart rate. Now with your typical EKG, you're going to have a whole 10 seconds of picture down here at the bottom. So, and if you counted it up, you can count all of the big red squares. There's 50 of them. 5 squares equals 1 second, so 50 large squares equals 10 seconds. Okay, so when we're looking through here, we count them 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. We have 13 QRS complexes. All of them are preceded by a P wave and followed by a T wave. This is a normal sinus rhythm. Because there's 13 complexes, if we multiply that by 6, 60 seconds, we'll get a heart rate of 78. Okay, so we have normal sinus rhythm, heart rate 78. When we're looking at the PR interval, is the PR interval less than one big block? Looking at the P wave to where the R is, yes, it's within that one big block size. So our PR interval is good. If it was longer than one block, we would be concerned about AV block. Looking at our QRS complexes and how wide they are. Is the QRS less than 3 small blocks? And looking at it, it looks like it's about 3 or less. So yes, it's less than that 3 block minimum. So that's good. Our QRS complex is small. If it was longer than that 3 block size, then we would be more concerned that there's a bundle branch block somewhere going on. Looking at the axis, lead 1 is positive, lead 2 is positive, so we have a normal axis. So there's no axis deviation. Looking at the lead groups, AVR, AVL, AVF, and the V leads, are there any suggested changes of acute coronary syndrome? I don't see any really bad ST elevations, any T wave changes that are suggesting bad ischemia. The ST segments, they're within about 1 millimeter of baseline, and I don't see any pathological Q waves. Okay. In the next slides, we're going to start talking about acute coronary syndrome and changes that we may see in our EKG readings for acute coronary syndrome, and eventually leading to Q wave or pathological Q waves. Okay. Then we'll get into the discussion of branch blockages, and then we'll save some more rhythm strips for the second lecture. This slide has a lot of information. I try not to overload the slides with a lot of words, but I think that it's good for everyone to have this all kind of spelled out for right, left, and circumflex arteries and the supply chain of blood. When we're thinking about acute coronary syndrome really results from a lack of oxygen getting to tissue that needs it. So you have this heart muscle that's beating constantly, and eventually, due to some sort of ischemia change, the myocardium isn't getting the oxygen that it needs, and this results in EKG changes and the signs and symptoms of acute coronary syndrome. Etiologies are varied. You can have atherosclerosis buildup alone. You can have atherosclerosis, which is enhanced with a bleeding or a clot, such as a thrombus that gets obstructed. You can have an obstruction by overgrowth or a diseased plaque. This happens with endocarditis, or you could have, vasospasm of a coronary artery, reactions to certain medications, such as smoking. Smoking can cause vasospasms, so you have different etiologies that can limit blood flow through these vessels. When we're looking at the right coronary artery, it supplies mainly the backside of the heart, the right side of the heart. In about 60% of people, it does supply blood supply to the SA node. In the 40 other percent of people, that comes from the left carotid. But looking at the left coronary artery, it supplies mainly to the left ventricle, that ventricular septum, and the anterior left ventricle, and the circumflex supplying to the lateral aspect of the left ventricle. When we're looking at muscle tissue, over here on the right side picture, there's a picture of transmural infarct, which goes all the way from the endocardium to the epicardium, and then there's subendocardial infarct, which is that teal colored space that just kind of protrudes into the muscular tissue. Depending on how long the muscle tissue goes without oxygen, and how much oxygen is being deprived of the muscle tissue, this can affect how much muscular death occurs in the endocardium. Vessel occlusion for too long, such as 2 to 6 hours, can cause infarction and death of that tissue. If the damage is beneath that endocardium area and it doesn't extend all the way to the epicardium, it's usually characterized as a non-Q wave MI. If the muscle is infarcted from the epicardium all the way to the endocardium, that is usually referred to as a Q wave MI, or transmural infarct. Looking at the leads that I have labeled up here, these can be somewhat helpful, knowing which artery supplies which space of the myocardium, and then what leads you should be expecting to see changes on. It's useful because myocardial damage tends to be localized to the portion of the heart that's supplied by those vessels or branches from the main vessel. So if you can, see a change on, say, lead 2, that can be significant finding for right coronary artery. So use all of the different tools in your toolbox to really figure out where is this change happening and what can we do to possibly fix or reverse this coronary syndrome. Talking a little more about acute coronary syndrome and T and Q waves. There are some normal findings for T waves. A T wave depression in a pediatric patient is pretty common, and this can persist through juvenile to adolescent years, termed a persistent juvenile T wave pattern. In adults, generally, that's not a normal finding. Generally, it's an indication of myocardial ischemia or bundle branch block or ventricular hypertrophy, that strain pattern checkmark. You can also have these kind of changes with pulmonary embolism, raised intracranial pressure. So there's lots of different causes besides just myocardial infarction that can cause an inverted T wave. Symmetrical T wave inversion tends to occur with within 2 to 3 days of the event. If it's a myocardial infarction, generally we see T wave inversion within 6 hours. This ischemic finding on EKG tends to return to normal within 6 weeks after MI, and if this change is seen in 2 leads in the same lead group, this is usually an acute change and termed an inverted T wave acute. Asymmetrical strain change for the T wave can result from ST and T wave changes. This is greatly associated with left ventricular hypertrophy. It's also sometimes seen in digitalis effect, which we'll talk about later. But that's generally what we see with those kind of T wave depressions. ST segment elevation. This is a big heavy hitter that you need to be very familiar with and able to identify. When we are looking at the isoelectric line where we measure any kind of amplitude, anytime we see the ST elevated greater than 1 millimeter from that baseline, about 2 millimeters, this is a primary indicator for ischemic damage, as this is one of the first changes to occur. Usually it occurs anywhere from the first hour or 2 of a MI event. This ST elevation MI change, or STEMI, on EKG will also be one of the first changes to return to normal. If you're looking at a timeline, ST segment will normally normalize within 7 days. So this is something that you can usually see sometimes within 2 to 3 days, but usually by day 7 it's back to normal. Whenever you see one of these kind of acute coronary syndrome changes, you want to confirm in 2 leads in the same lead group. Sometimes you can have a elevation in just 1 lead and it be a non-specific lead change. This is often notated on EKGs when you have them print off on the 12 lead. It'll say non-specific T wave abnormality. It can be really irritating when you're looking at an EKG and you just jump right to that that little comment box, because you see it over and over and over, and it seems like, well, is there an EKG without non-specific ST changes? But when you're looking at it, you want to look in more than 1 lead. When we're looking at Q wave changes, Q wave is a big indicator for ischemia, and you can either, when you're thinking about Q waves, you want to look at its width versus its depth. A Q wave, which is that first deflection on the QRS complex, if it's greater than 0.04 seconds, or at least 25% of the depth of the entire complex, then that is significant for Q wave or pathological Q wave. So I have here on the screen a little ST elevated finding, and you can see under that red area that deflection is about half of the whole QRS complex, so it's definitely meeting that at least 25% depth criteria. By its nature, infarction and cell death is a permanent change in the EKG. When you see it in at least 2 leads of the same lead group, this usually will indicate infarction. It appears during the acute phase of the MI and will remain when the T and the ST segment changes have both returned to normal, because this is the pathological Q will remain forever. So when you're looking at an EKG, just because you see pathological cues doesn't mean that a patient is in an acute coronary syndrome. You have to look at the rest of the EKG to evaluate for T wave and ST abnormalities. So the way that you can tell an acute from an old MI can have a Q wave without any kind of ST or T wave changes. So just the presence of a Q wave without any symptoms or without any other type of criteria, that can usually let you know, hey, this patient's had an MI in the past. As I talked about in previous slides, you can have Q wave MI, and you can also have a non-Q wave MI. Non-Q wave MI is generally related to patients that have partial damage to their endocardium. When you were looking at the picture earlier and it only showed the ischemic damage going part of the way through the myocardium, as opposed to all the way from the endocardium to the epicardium. Generally, this will be shown as a non-Q wave MI. There can be no changes to the EKG, so when you're looking at the 12 lead, it might have no findings, which can be normal with a non-Q wave MI. This could also be, found with non-STEMI patients, so this is something that you might see. Other times we'll see where the patient's Q wave has a squared off ST depression, as you can see here in the second picture to the right, and then sometimes you'll have very deep T wave inversions. Generally, this T wave inversion should be about 10 millimeters deep, or two of those big boxes when you're looking at the box sizes. So that can be, a sign of a non-Q wave MI. Some changes that I wanted to just kind of list here for your use so that you can have reference to them later. I kind of touched on non-specific ST and T wave changes. These are generally not pathological. They can include some minimal changes to the ST or T wave. When you're looking at, changes, maybe it's only in one lead in the lead group, so it's not very, defined as far as having two depressive leads in the same lead group. Some other findings that you might see on EKG: pericarditis, digitalis effect, hypokalemia, hyperkalemia. Hyperkalemia is a little bit easier to pick out than hypokalemia. Hyperkalemia with those tall tinted T waves in all the leads, that can be a big indicator and is a little bit easier to see than hypokalemia, and sometimes it's not even present for either of them. And for patients that have had a stroke, they will have very deeply wide splayed T wave inversions at times, so that's also something you can look for. Over the next 4 slides, we're going to go over conduction defects. This is your intraventricular conduction problems, such as your AV block, whether it's right bundle branch, left bundle branch, or a hemibundle branch. So first we need to just quickly go over what's normal anatomy. Over here on the picture, it shows the AV system, how this breaks off from the AV to the bundle of his before branching off to the left and the right bundle branches. The right bundle branch, once it branches off to the right side, there's no further division other than the Purkinje fibers and all the little fibers to get the electrical impulse out. Once the electric conduction goes to the left side, it can further break down by the left posterior versus the left anterior fascicular. and this can cause a block on either of them. It can block both of them if it blocks in the left bundle branch before it separates. So there's a few places that you can have a block. Some people will, discuss a trifascicular block, and this is kind of a misnomer. You either have one-sided block, or you have a biphasic block, bifascicular block, where the right bundle branch is blocked, and you either have blockage of the posterior, the anterior, or the left bundle branch entirely. Okay. When we're looking at the time lapse over here, this is a good kind of area to understand how the electrical impulse is being processed throughout the electrical system. You can see that as the electrical impulse is hitting the Purkinje fibers, this is right before everything really depolarizes and you get that big QRS complex. So right there, that impulse where it passes the Purkinje fibers, that's where you get that first downward Q. And that's going to be important when we're talking about some of these blocks, because that Q wave is a bigger deal in looking at some of the bifascicular or the hemiblock. In the EKG, what we're going to see, whether we see a right bundle branch or a left bundle branch, is a widening of that QRS. The hemiblocks do not cause that EKG change. Generally, they still have good conduction because there is still part of that left branch that's working, whether it's the posterior or the anterior. Okay, the right bundle branch. This nerve fiber is a little bit more fragile than the left bundle branch. The left bundle branch is a little bit thicker and stockier to really transmit that electrical impulse to both branches quicker. The right bundle branch is just a little bit smaller in size, and what we see with a right bundle branch is that the left ventricle will depolarize normally. So that left bundle branch, it's already going through, it's depolarizing, and the right ventricle will depolarize in a cell-to-cell fashion because it doesn't have that conduction network through the Purkinje fibers. So it's going to be slowed. Since it's depolarizing abnormally, the EKG will be seen with a right ventricular lead 1 generally. And in that lead 1, 2, and 3, when you're looking at those, you'll generally see a M shape RSR pattern, and you can see it best in V2 here in the picture. It has that M shape complex, whereas for a right bundle branch block, we'll generally see a slurred S wave or a W kind of formation. I can see this best in V6. So when you're looking at V6, you see how the QRS complex has that kind of slurred check mark S wave right there. You can also see it in AVL and lead 1. So those are some places that you may want to look for an M or a W pattern with a right bundle branch block. Right bundle branch block, we see this with right ventricular hypertrophy pretty frequently. Pulmonary embolus is a differential that you'll want to consider, along with ischemia, myocarditis, and cardiomyopathy. Concerning a left bundle branch block, it's going to be kind of similar to a right bundle branch block, except kind of switched around. The way that it affects the conduction system is just flip-flopped. So for a left bundle branch block, the right ventricle is going to depolarize normally. So that electrical impulse is going through. The left ventricle will depolarize cell to cell, so it's going to be slowed. This is going to cause the same kind of W and M formation, except it's going to appear on different leads. So your W, that dominant S wave formation, you can generally see it in lead 1, V1, I mean. And so you see that deep, deep S wave. And on V1, you can see how deep that is. That's a deep kind of complex on the QRS. And then on your R wave, you're going to see that M formation. You can see it on lead 1, your AVL, and your V5 through 6. V6 and V5, you can see how that S kind of slowly kind of tapers down. And then on AVL, you see that kind of M notching formation as well on lead 1. You can see that kind of lazy M kind of just smoldering off. They can be, notched M's. They can kind of droop like as it does in lead 1. But what you're seeing is these widened QRS complexes with both the right bundle branch and the left bundle branch. You see these wide spaces that are too big for a QRS complex. These can be from, several different findings. We're going to be concerned with anterior MI, hyperkalemia, ischemia, those kind of findings. But you have to look at your patient to see what you're thinking goes along with it. Okay, there are 2 fascicular branches off the left bundle branch block. We're going to talk first about the left anterior hemoblock, hemobundle, and before we talk about the left posterior hemobundle. The left anterior hemobundle, it innervates the anterior and superior walls of the left ventricle, whereas the left posterior hemobundle innervates the posterior and inferior walls of the left ventricle. When you're looking at left anterior signs versus left posterior signs, they're going to be flip-flopped. So your QR complexes on one are going to be the RS complexes on the other, and vice versa. So when you're looking at it, you can look at where are my QR complexes, and that can kind of tell you if you're having a left anterior versus a left posterior. The other thing that I want you to look at is your axis deviation, looking at leads 1, 2, and your AVL and AVF, and seeing if there's any kind of axis deviation. Okay. When you're looking at either fascicle losing its conduction, the left ventricular area depends on remaining conducting hemobundle to depolarize. So if you have a hemiblock, you still have that other part of the left bundle branch that is still working. So generally, just having one of those little hemiblocks blocked will not stop a QRS from going through, and it won't cause a big widening of your QRS. So when we're seeing these left anterior and left posterior hemoblocks, you're not going to see that big QRS widening as you do the other full blocks. Okay. The left anterior hemoblock is really the most common hemoblock. It forces depolarization along with the posterior fascicular area, so that's going to shift your QRS axis and cause a left axis deviation. So whenever you think left anterior, you're going to think left axis deviation. Okay, and whenever you see a left axis deviation, this should be kind of on your mindset as, oh, is this a left anterior hemoblock? You're going to look and see these QR complexes. You're going to see just a little bit of a dip before that QRS complex. And you can see that in lead 1 and your AVL here. Okay. A lot of times these left hemoblocks they can be pretty benign. They do not necessarily, note any kind of impending doom for your patient. A lot of times we'll see this with hypertrophy and the other things that we have listed with axis deviations on those previous slides. So those should be on your mindset along with left anterior hemoblock. A left posterior hemoblock is not common at all. Generally, a left posterior hemoblock accompanies a right bundle branch block, so it's actually a bifascicular block. Generally, in order to diagnose a left posterior hemoblock, you need to rule out other causes. So when you're thinking a left posterior hemoblock is happening, you're going to see that right axis deviation, and you want to think of what else could be causing that right axis deviation other than just a left posterior hemoblock. Pulmonary embolus, tricyclic overdose, all of these are, some viable differentials to consider. With your left posterior hemoblock, you'll have that S complex, that deep wave seen in lead 1 and AVL, whereas that QR complex that has that little bit of a dip, you're going to see that in leads 2, 3, and AVF that I have circled in green. You can see how it just dips just slightly before that QRS complex. On this slide, I have some ventricular conduction blocks and axes to kind of think about, whether it's the M or the W, and how wide the QRS complex is. I think this is helpful to kind of think about your different ventricular conduction blocks that we have just talked about. Okay, in the next lecture, we're going to talk about different arrhythmias, starting more with lethal arrhythmias, and we're going to do some practice. You should be able to print out the EKG slides that we're going to use for lecture 2. That way, as you're going along the slides, we can look at them together and you can write on them and practice. So I look forward to talking to y'all in the next lecture. Bye-bye.